I have a very simple case presentation, no big challenges here. I was informed by Milan and Keyur that we should have cases which are very simple, very clinically oriented and helps us to go through our clinical practice. I believe these are the things that help me keep myself a little better off as a clinician. So that's what I'll present. We had a 62 years old lady who was hospitalized for a total knee replacement, and she was non-diabetic with no medical therapy on, and I gave her a pre-operative fitness which was okay. She underwent a procedure without any problems, and on the second post-op day she was put on a prophylaxis low molecular weight heparin. See, normally it should be done within 12 to 24 hours if you go by the conventional guideline, but she had a drain on, so the orthopedician said after 24 hours. On the fourth day, she had an episode of sweating blackout and acute onset of shortness of breath after using the bedpan, and her saturations dropped. She became quite dyspneic. She was transferred to the CCU. Her temperature was about 39 degrees and pulse was 96, not a great tachycardia. Blood pressure was by 80 by 60, respiratory rate was 30. Her SATs were 72. Her neck veins were prominent. She had no RALs in the lungs, and she had a gallop, a loud P2, a short systolic murmur somewhere in the left parasternal area. She required about 12 liters of oxygen by the rebreathing mask to just about maintain her saturations to somewhere around 88, 90. So what is the clinical diagnosis? I keep it all for you. You can go on doing the arithmetic in your own mind because we don't have those buzzers here. So one is we could have acute coronary syndrome, AMI. Second, massive pulmonary embolism. Third, a non-massive pulmonary embolism. Fourth, acute aortic dissection. How many say it's a massive pulmonary embolism? Just a raise of. And non-massive pulmonary embolism? Non-massive pulmonary embolism. And aortic dissection? No, no dissection of aorta. Okay. Alright, this is apparently a pulmonary embolism, right? We have a thrombus going on from the veins and it's gone in and gone to the lungs. The thrombus in the veins are usually where the venous valves are, and this is a floating thrombus which undergoes an embolization, and you can pick up this, you can pick up this, a small message. You may not be able to pick up this also, as we discuss later. Now, you see, this is important. If you are going to define a pulmonary embolism strictly by the definition, it will go by the blood pressure. This patient's BP was 80 systolic. If the systolic blood pressure is less than 90, that's massive. If it's more than 90, it's non-massive. Both patients are going to be breathless, they'll have tachypnea, they'll have everything. So the definition clinically goes by the blood pressure, and this is very, very important to know because your therapy is going to be very aggressive. These were her blood gases, and then of course we treated her, and you could see in about 7-8 hours the PO2 which had dropped came up to 80. You see, and the SATs which had gone down came up to about 96.8. So as we discussed ahead, I have shown you these blood gases, this patient did better. Which symptom is not common with pulmonary embolism? You see, she had what? Do you see, she had a little fever, syncope, seizures, polyuria. What do you say? Which is not common? Alright, polyuria, fever, alright. Amongst the symptoms, these are the common ones. So you can see fever is quite common. Syncope can be the first manifestation of a pulmonary embolism. This lady had dizziness followed by episode of blackout. A fever was recorded. You can have seizures, you can have so many things. So besides polyuria, everything else can occur. Let's keep that in mind. Which manifestation is least common in pulmonary embolism? We did her ECG, by the way. Her ECG showed a partial RBBB pattern, as I showed. There was no S1Q3T3 in this patient. So which is the least common, you think, in clinical work? Sorry, the RALs are the least common. Let's see the entire literature and a very important study called PIOPET. This is what you will get in pulmonary embolism. RALs occurs next to tachypnea. They occur in 58% patients. The least are the ECG changes. They occur in 20% patients. Yeah. You see, I think these are important things for us to know. If you look down, you can have increased second heart sound with this patient had. This patient did not have a tachycardia, and you may not have it in 55% cases. She was febrile, and you do find it in 40% cases. She had sweating, she had a gallop. We'll come to this later, and you can have a cardiac murmur. ECG changes, of course, are there, neither sensitive nor specific. Now this patient was on low molecular weight heparin for 2 days. Is it common to have an embolus on short DVT prophylaxis? What do you say? Very common. 20, 30, 50% cases. Loudly, what do you think? How many of patients who are already on a DVT prophylaxis can throw a embolus? Uncommon? Oh, that's quite a bit. No, not 20%. White cell count as high as 20,000 is common in patients with PE. Now, new PE can occur in the hospital beside therapeutic anticoagulation. You can have patients who will have a thrombus, who will have a floating thrombus, and they still continue to have a pulmonary embolism. If you look at the literature where you have a pulmonary embolism, though the patient has been on anticoagulants for a short period, it's about 5%. So you have incidence there. We did a leg vein Doppler in this patient immediately. At bedside, we called the radiologist, besides all the other tests which I will describe, and it turned out to be normal. He said there is nothing there in the legs. What do you think? It will exclude the pulmonary embolism. You must do a good compression study. You must now say, well, it's nothing to do with DVT. Start looking for factor V Leiden, a hematological study, or any other hematological study, for example, protein CS, antithrombin 3. Say loudly, what do you want to do? It doesn't exclude a pulmonary, not at all. In fact, a negative ultrasound does not even rule out a DVT, forget about a pulmonary embolism. Because a lot of DVTs occur in areas, particularly in the venous valves, that are inaccessible to ultrasonic examination. Before you say it's negative, you must go centimeter by centimeter compression testing. My radiologists are very busy, like you clinicians. They don't have time to go centimeter by centimeter. They'll go zup and they'll say, hey, nahi hai. That's it. So we missed it. In 2/3 of the patients with PE, the site of DVT cannot be visualized by ultrasound. So, a negative duplex does not markedly reduce the likelihood of PE. Just because the venous Doppler was normal, you must not say this is not pulmonary embolism. If you have to investigate, the commonest in hematological causes is the mutation of factor V Leiden. And the next common are all the other stuff, the protein C, S, antithrombin 3 deficiency. They would count for about 5% or 10% of all young patients who come with PE. So please keep that in mind. Alright, the X-ray was normal at presentation. In the ICU, we took a bedside X-ray. That, what do you think? It's common, uncommon, rules out PE. Say loudly. Common, very nice. Of course, it's common. Initial X-ray chest could be very well common. In fact, on rare occasions only, you find the Westermarck sign, where you will find that the pulmonary artery has got embolized and there is a distal oligemia and there is a sharp cutoff. That occurs quite uncommonly. However, our problem is over a period of time, they will start showing atelectasis which can progress to a small pleural effusion and elevated hemidiaphragm. And this can become absolutely indistinguishable after 2 to 3 days from a pneumonia. It will all look the same. And a relatively later finding is the Hampton hump, where just above the diaphragm towards the hilum, you will find the triangular shadow. So the two classical signs which are described, the Westermarck sign and the round hump, the Hampton hump, might not be very commonly seen. So what else you will do in this patient? Will you send a D-dimer latex agglutination assay, anti-proBNP, white cell count, Doppler echo? Say loud. Okay, probably you do everything if you want to. But a word about D-dimer, because the cutoff limit is 0.5 milligram. Please remember, a lot of laboratories still continue to use the latex agglutination test. They are notoriously bad. They are quite unreliable. Their sensitivity is pretty poor. So if you need to use anything, you must use a ELISA test. A ELISA has a 96 to 98% sensitivity, and only problem is in patients where your index of suspicion is not very high, you can be in trouble, because patients who have a trauma, who have recently undergone a surgery, can have a positive D-dimer without any embolus, right? So we keep that in mind. Echo, of course, is very, very helpful. It shows you the hypokinesia of the free wall, a lateral wall septal shift. We saw all that in this patient. We saw the pulmonary artery pressures were as high as 72, so it was quite a massive embolism. Troponins and the NTP-proBNP will help you in assessment of the right ventricular load. If you know the right ventricular load, then you are pretty well off trying to understand the management of this patient and how they are going to do over a period of time. There's a new test called the ischemia modified albumin, the IMA. It's better than the D-dimer. I am not aware of the utility in our city, at least we don't use it, but maybe one might try to look at it further. What is the approach to this patient's hypotension? 80/60. IV fluids, inotropes, streptokinase, tenecteplase. Tenecteplase, all right, okay. Fluid load, let's be careful because still you do not know how the patient's hemodynamics are. You know, increasing the fluid load might actually worsen the outflow pressure. So you have to be careful about how you give the IV fluid. You can give a bolus challenge, look at the patient's clinical condition. If it deteriorates, slow down on the fluids. Fibrinolytic therapy, and it's very important. A rapidly acting fibrinolytic therapy should be immediately administered. Even if the BP came up, these patients with the IV fluid, BP came up to 100, but then we said nothing doing. We just gave her the thrombolytic therapy. The thrombolytic therapy of choice, as we said, is the tissue plasminogen activator, the Activase. We gave this patient tenecteplase. And in that hurry, this patient's weight, you know, we did not check, that's a mistake. So we had asked the patient, she said 60, 68, 62. So we gave her about 50 milligrams of bolus of tenecteplase. On hindsight, that was a mistake. This patient really never required more than maybe 30 or 35 milligrams. Importantly, you must give heparin to all patients right at the start. No waiting. You want to give a low molecular weight, go ahead. If you want to give a heparin, go ahead. Why? Heparin does nothing to the clot. It's going to remain where it is. But what is going up, what is going to embolize, that's the part it will try and take care of. And that drops the mortality down in a massive embolism from 30% to 10%. So please keep this in mind. It's absolutely essential to heparinize this patient. Now what is the therapeutic strategy? A low dose heparin, high dose heparin and warfarin after 5 days, high dose heparin and warfarin straight away, low molecular weight heparin and warfarin straight away. Tell me. Huh? 4. You want to start heparin and warfarin straight away? Okay. Now let's understand this. Number one is that your heparin dose has to be much higher if you're using it, the conventional, than a coronary thrombus. The reason being you're dealing with a hypercoagulable crisis here. It's not like the coronary artery where there is just a situation of platelet adhesions to a given vessel. And you may use whichever one you prefer. If you are using heparin, the dose as you see is very high, 10,000 units IV bolus followed by the drip, 20 units per kilogram per hour IV. Then you check the APTT. If the APTT after 6 hours is low, then you administer another 5,000 units. If it's high, drop the drip. If it's very high, hold the heparin drip for 1 hour. These are the guidelines for using heparin. And the most important thing, don't start warfarin straight away. You just can't do it. You see, when you start warfarin without a patient being anticoagulated fully, warfarin itself is going to produce a hypercoagulable state. If you anticoagulate with heparin before starting warfarin, then it will cause a clot extension and recurrent thromboembolism in 40% of the cases, vis-a-vis 7% of the patients where you don't start warfarin. So wait for 5 days. Wait for 5 days. Continue with heparin. After 5 days, start warfarin. Continue heparin for 5 days more. Why? The procoagulant factors which are produced as a result of the oral anticoagulant will go down. That's the way we look at it. Keep the INR around 3, so that you are okay off from the hemorrhagic strokes, and give it for 6 months. In the OPD patients, you know, this is always a question, how long you will continue? 6 months for sure. If you find that the underlying risk factor is irreversible, then of course you will have to be careful, and then you will have to extend it further. The lower items are something which we need to remember in clinical practice, 5 to 15 milligrams orally. Now, will you give this patient a IVC filter? Embolus has gone. Will you give a IVC filter? Yeah. Okay, let me tell you something else. See, what happened is after we give tenecteplase and we pushed heparin, unfortunately this patient had a bleeding. She had a hemarthrosis. We had to give her 5 transfusions. We landed up in a mess like no man's business. and we had to give her a frozen plasma to extended days in the ICU, so we're in trouble. Now, will you give her IVC filter, yes or no? Okay, I did not wanted to do the thinking, so I left it to someone else. The primary indication for a IVC filter is if you have a major bleeding complication during anticoagulation. This patient is not going to do well, as I show you. So this is a situation probably where you can put IVC filter. She had hemarthrosis, required frozen plasma. We stabilized and discharged her. The follow-up echo I did was looking pretty good, 30 when I did it last time. She's on warfarin as an outpatient. Now my problem. The surgeon said he aspirated the hemarthrosis after 2 days in the ICU. She's gone home. But then he says we'll require a little procedure because the thing is not very stable. She's on warfarin. My last question, and I'll take that 1 minute with the chairman's permission, is that what will you now do? Should I stop the warfarin 5 days prior to a surgery and operate only if the INR is absolutely normal? 2 days prior to surgery, I stop warfarin. Start with a low molecular weight heparin day before the surgery. Continue with warfarin, don't bother. Yes. Third one. Start with low molecular weight heparin day before surgery. Okay, very important. You must stop warfarin for 5 days before the surgery if the embolism has occurred in 1 to 3 months duration. This is a recent thing. I'm talking of just 1 month back. So you have to stop 5 days prior. On the 1 day prior to her surgery, you check her INR. If it is 1.7 and more, you give 1 milligram of vitamin K. If it is on the morning of the surgery, it's still 1.3 to 1.7, give a unit of frozen plasma. If 2, give 2 units of frozen plasma, but you can take her for surgery. If it's 1 to 3 months, 4 doses. Otherwise, 5 doses of warfarin will have to be withheld before surgery. And lastly, the IV heparin which you have to give a day prior to surgery can be done only if you require it. You will have to start with the IV heparin, stop it 12 hours before the surgery and restart it again 6 hours after the surgery. That is the conventional way in which we manage this patient. Thank you for the patient hearing and thank you, sir.